Hey team, before we dive into today's episode, I've got a quick favour to ask. The Women's Football Hub merch store is now live, and every purchase helps support our work as a non-profit championing women and girls football from the ground up. There's something for everybody, adults and kids. There's loads of colours and sizes, and your support helps us grow the game one piece of apparel at a time. Just head over to www.womensfootballhub.com to check it out. Thanks for backing the hub, and now let's get into the episode. Hello and welcome to Women's Football Hub. I'm your host for this episode. I am Carolyn Kent, and I'm delighted to say that I am joining yet another student co-host. She's a physical therapy student from Arcadia University in Pennsylvania in the USA. Welcome to the show, Lotte Black.
Hey guys, I'm Lotte. Super happy to be here. I'm an Arcadia student, love sports, love exercising. I was a strength and conditioning coach and just love working with females and teaching them everything that they need to know to stay healthy and keep exercising.
Fantastic. And from your perspective, is this your first ever podcast that you've been on?
This is my second, actually.
This is your second. Okay, bit of experience then. I'll look forward to that with the delivery of questions, etc. Probably be better than me, and then you can take over from me whenever I'm on holiday because I'm always looking for people to help me out. And sometimes. So let's get on to our guest today. Our guest today is a consultant trauma and orthopaedic surgeon specialising in children and adolescent knees. She is chair of the Women's ACL Orthopaedic Steering Group and is also an ambassador for the injury prevention charity Power Up to Play. Welcome to Women's Football Hub, Miss Morgan Bailey.
Thanks so much, guys. Thanks for having me to chat about this. It's really exciting.
You're very welcome. And obviously you and I realised we were kindred spirits, didn't we? Because we were chatting about all the things that we kind of have those views that align with regards to injury prevention, don't we? And we spend our life trying to go, we don't need to see you with a torn ACL. That's kind of what we do, isn't it?
Absolutely.
Now, before we get into the sort of details, let's chat a little bit about your background and your work in youth sports surgery.
So I'm a consultant paediatric surgeon by basic trade, but I actually started life wanting to be a knee surgeon. So I was always interested in working in sports with athletes. I really loved knee surgery. But then I grew aware of paediatric knee surgery as a sort of subspecialty. So I went and did a paediatric fellowship and really realized I preferred working with younger people. So now I work as a hub and spoke paediatric orthopedic service between Southampton University Hospital and Portsmouth Hospital with a specialist interest in knees, which in kids is a lot of sports injuries.
And Lotte, I believe you've got some questions to start us off, haven't you?
Yes. So Morgan, we know you're an advocate for injury prevention. You told us how you got started, but was there anything that sparked your specific interest in this field?
So I first heard about injury prevention as a concept at the British Orthopaedic Association meeting as a late stage trainee. And Nev Davies is a consultant orthopaedic surgeon in Reading. He's one of the trustees for the charity Power Up to Play that I'm now an ambassador for. And I heard him talking about injury prevention and how wildly you could reduce adolescent knee injuries by implementing injury prevention warm-ups. And also what I hadn't realized at the time is how we'd seen this massive increase in adolescent ACL injuries over the last 20 years. And I just remember being sat in that meeting and thinking, this makes total sense and I want to be part of it. And then when I got my consultant job, I badgered Nev, so I knew him as a junior trainee, saying, how do I get involved? And the rest of it unfolded from there.
Yeah, and of course, ACL injuries are a significant issue in women's football. And actually, there's been a lot of chat about them recently. I am tearing my hair out on social media with what I see. It gets 50, 60,000 shares, for example. There's an epidemic. I'm like, there actually isn't. There isn't an epidemic. It doesn't matter how many times I say it. Nobody seems to be hearing those words. But let's chat about what makes young female players particularly vulnerable, because there's a lot of things flying about on social media. And I want to make sure that from a surgical perspective, what do we know?
So what we know, well, we've got twofold there. We've got adolescents being at higher risk of injury. We've seen that in the data. There's been a 20-fold increase over the last 20 years. So they are their own high risk group. And the theory behind that is probably multifactorial. One is that kids are probably more engaged in sport specialization these days. So they'll tend to do one sport rather than lots of different sports. So their kind of neuromuscular balance isn't going to be as broad as it might have been back when they were all climbing trees and running around doing lots of different things. There's that element. And obviously with the advent of screens, some kids are less active and then all they're doing is playing their football. I think we've also got the fact that kids, when they are playing sports, are starting to play to much higher levels. So they're playing more frequently, more intensely, higher higher burden of activity, which then has a knock-on impact on the higher injury burden. And then we're probably realistically picking more injuries up because of MRI scans being so widely available. And then you add into that probably more girls are playing more high risk sport. And we know that girls and young women are at risk for their own independent reasons. And I can go into that in a minute. That's why your adolescents are your high risk group. Women are higher risk for, again, a multitude of reasons. And I personally like to look at that as sex-based and gender-based reasons. So you've got your sex-based reasons, which are that women are more likely to have certain anatomy that predisposes to injury, like valgus or knock-knee alignment, narrower notches inside the knee joint. They are obviously susceptible to hormonal fluctuations, and we know that you're probably higher risk in your pre-ovulatory phase of your menstrual cycle. And those are all your sort of the reasons relating to being female sex. But then you've got your gendered reasons, and that's reasons that relate to being a woman in society and the impact of systemic sexism, essentially. And that is the fact that all the kit's designed for men. Your people talk about your boots, and women are more likely to have the poorer quality pitches, the less experienced support staff in their clubs. They are not going to have the same strength and conditioning input. If you look at academy football, for example, your young boys are going to get strength and conditioning input from a much earlier stage than your young women. So you've got with your youth athletes, you've got the fact that they're teenagers, which puts them at risk, and then the fact that they're female. So for me, teenage girls are the group that I want to try and support most. And really interestingly, they are the group that disproportionately benefit from injury prevention warm-ups at a grassroots level.
Let's chat about age-related differences and how ACL injuries present in teenage girls compared to senior players. Now, I'm sure that when you're doing surgeries on younger girls, you'll have growth plates, etc., to take into account. Is that right?
Yeah, absolutely. I mean, if you're talking about the injury, how it presents and the mechanisms, I think one of the key distinctions as well is between your grassroots players and your elite players. And I think that gap is narrower in the women's sport because your elite women aren't as far away from your grassroots women as they are in the men's game. But what I see is a lot of missed partial injuries, just a lot of missed initial injuries. And so when they do eventually present and get scanned, it's not uncommon for them to have had quite big injuries. Then when you take into account the fact that if they're growing, you've got to deal with their growth plates. The reality is, particularly because girls finish growing earlier than boys do, the reality is actually a lot of the girls don't have lots of growth left. And I would say I worry more about my male adolescents' growth plates than the girls because they've often not far off growing when they present.
Yeah. I think it's one of those things that when you're dealing with young children, you've got obviously peak height velocity that you want to take into account. You've got and I think I was talking to somebody recently, 14-year-olds can look like 16-year-olds and 16-year-olds can look like 12-year-olds. And I think that adolescence thing is we maybe need to take that more into account.
Again, boys and girls, and like everything in the whole ACL sphere, you cannot treat boys and girls the same because they reach lethal maturity at different ages. When teenage girls hit adolescence, their hormones kick in and you're dealing with a whole different entity. And both boys and girls are a very dynamic picture through adolescence, and both physically and emotionally. And I think that's really taken into account.
Sex differences between a male and female, so those hormonal factors, and the menstrual cycle for females they can affect ligament laxity. So how strong is evidence for this, and how does this influence kind of your surgical decisions?
So the evidence isn't great. I think there's quite a nice paper that showed that the injury risks, the risk of ACL rupture is greatest in the pre-ovulatory phase of the menstrual cycle. And then we know theoretically the influence of estrogen and relaxin on your ligament laxity. But beyond that, there's not lots of concrete data. We're actually only really just validating data on how to check hormones, because traditionally the gold standard was blood estrogen level to look at the impact, and getting blood samples off athletes on a regular basis through their cycle is really challenging. I think they're now starting to be able to get at either urinary or salivary estrogen, which is much easier to then check. So I think what some clubs are doing at more elite levels is they're just cycle mapping their individual players, because the reality with the menstrual cycle, as everyone here will probably know, is that no one is the same. And where even your own cycles may not be the same. So being able to map that to your injury risk is actually quite difficult. And actually, a really nice quote I heard at the women's ACL injuries in footballers meeting in Barcelona that I went to a couple of years ago. And someone stood up and said, actually, we're not really going to know the full influence of hormones on women's ACL risk until everything else is equal, because probably the rest of it has a much bigger impact. And with regards to surgical considerations, the reality at the moment is I don't take it into account. It's not something we consider, but I do have a colleague who has an interest in trying to identify whether there is an optimal point in the cycle with regards to your ligament laxity to perform surgery, because maybe if your ligaments are tighter when you put them in and you harvest your hamstrings, for example, does that then mean that you have a lower re-rupture rate later? We don't know, but it'd be an interesting question to look at once we've figured a lot of the other stuff out.
Awesome. That's really great information. So is there a difference in ACL patterns between female players who are still growing compared to those who have reached skeletal maturity?
The only real anatomical difference would be in your younger athletes, they can get what we call an avulsion injury, where you take a bit of the bone rather than a ligament rupture. And that's just with any growing patient that the bony interface is weaker than the ligament interface. And the advantage, it's called a tibial spine avulsion fracture. The advantage of one of those, you see it on an x-ray and you can fix them and it saves a full ACL reconstruction. But other than that, in terms of tear patterns and things like that, I don't think we've got any evidence there's a significant difference.
Yeah. Let's move on slightly to surgical options and decision making. So obviously, you consult an orthopedic surgeon. You will be making these decisions on a regular basis. And I'm going to bring in a couple of maybe slightly controversial things that are coming up that I'd really like a surgical opinion on. I really would. So when a young player tears their ACL, how do you decide, first of all, between surgical and non-surgical management?
I have a bit of a standard spiel for all my patients, because I think it's really important as a surgeon we have to offer people surgical and non-surgical options, and we have to give the risks and benefits of both. So I tend to tell people that with an absent ACL, you've got a 70% chance of being able to run in a straight line following physiotherapy rehab. You've got a much smaller percentage chance of being able to play cutting sports like your football, netball, things like that without an ACL. And the risk of doing those sports without an ACL is injury to your cartilage and your meniscus. So most commonly kids have come in because they've had a football injury or a netball injury or a rugby injury and they want to carry on playing their sports. And most commonly the conversation is, if you want to carry on playing your sport, which is an entirely reasonable goal, your knee is probably safer with an ACL in there. And that tends to be how that conversation goes. But I'm really mindful, because particularly when you're dealing with teenagers, like under 18s, your 16-year-old patient, they might look like an adult. You might think they're an adult, but they are still there with their parents. And you've got to have a conversation with both the patient, the child, adolescent, and their parent, and get everyone on board with the decision-making.
Yeah, and I think there's a lot of things that need to be taken into consideration with regards to whether you go in surgical or non-surgical. What are the most common graft choices for young female athletes? And are there risks of certain options for still developing players?
Generally speaking, in your younger patients, your non-elite athletes, I think most people will use a hamstrings graft. We are seeing more use of the quadrupled single hamstring technique. And there's some evidence that it's got increased biomechanical strength. It's what I do because it's a short, stiff graft essentially. And so your bone will fill in around it. So for me, you're maintaining your kind of bone stock, and you're preserving their hamstrings. You often get a bigger graft, which is something you want to aim for. You want the biggest graft you can within reason that's going to fit in that patient. When someone's still growing, there are certain options that are off the table. For example, if you're still growing, you don't want to use like a BTB or bone patella bone that you often see in your elite athletes, because you don't want a bone block around where your physis is, which is where you often end up plugging the graft in. And then if you look at things like your quads tendons, that's becoming a popular graft, but we don't really have the evidence yet for that, although I think that's going to be coming out in the next couple of years. The data from Al Getgood's team in a couple of years about how that's faring in your adult population. The other option you have for your growing patient is an extra-articular ITB graft. So in my much younger patients, and this is a lot less common in your sort of 8, 9, 10-year-old ACL rupture, we're starting to see more extra-articular reconstructions where you take their own ITB and essentially feed it in and out and around the joint, and then no bone tunnel, so you're not disrupting the physis at all.
I'm going to go slightly off piece here. What's the youngest age that you would consider needs an ACL? Is there a kind of cut-off point where you're like, absolutely not, we're not touching that?
With the extra-articular procedure, then I think you've got all options on the table. The youngest one I've done, it was 7, and she had a trampoline injury and a meniscal tear.
But see, when I think back over my career, right, some of the worst injuries I ever saw were trampolines.
Oh,
Like,
we had
they were terrible. It's trampolines. Everyone goes on about football. I'm like, no, trampolines. Like, we need to do something about the trampolines. So let's go on to kind of surgical management. Now, this is something that's been coming up, and there's a lot of chat about this. And I really wanted to bring this up, but I'm also very wary on the podcast about being super controversial. But cross bracing, right? The way that we can potentially heal the ACL, only applicable for very certain patients. And obviously, you're working with a younger cohort. And I think most of the evidence is maybe in a little bit older than the population you would be dealing with. But let's talk about the cross bracing protocol. So this is where we effectively brace the knee 90 degrees for 12 weeks. And we're looking at, can we heal the ACL rather than actually having surgery? What is a surgeon's take on that at the moment? Appreciate it's your personal opinion. I'm not asking you to speak for all surgeons all over the world. What's your take on that?
I think it's making the UK knee community quite nervous. I've heard it talked about a couple of times, and I think the group have done some really good work, and they've got some really high volume patients and some robust work that's been done so far, but they haven't completed everything. They don't have all of the data. I don't think they have the answer yet. I think it's really interesting, particularly when we work in an environment with limited resources and wanting to avoid surgery. I think it's very reasonable to explore it, but I think it's got to be looked at closer. And I think it's probably important that they make sure they've got surgeons involved in the conversation. My one slight concern with it is I can't remember if their data is in younger patients, but they are talking about it being something that's useful in younger patients. And my worry is that actually the vast proportion of adolescent ACL injuries that I see don't really fit their criteria. They often have other injuries like a meniscal tear. Kids have a habit of absolutely trashing their knees because they do the injury and then they just crack on and carry on playing. And so I'm not sure that many of them would fit into their criteria anyway. And I would also worry about that time. Kids want to get back to play as quickly as possible. And they're out for at least a year post-surgery. If you then have to add on that time of trialing conservative treatment, I'm not sure how appealing that would be to those groups unless we had some really robust evidence for them. In summary, I think I'm open-minded to it, and I think it's really important that we're open-minded to it, but I absolutely wouldn't advocate anyone playing around with it or trying it out at the moment until we've got more evidence.
That's good enough for me. I thought, do you know what? At some point, Carolyn, you're going to actually have to ask questions that might cause a little bit of debate. But I also think that we need to almost sometimes work closer together and get multiple opinions. Because let's be honest, we are a multidisciplinary team for a reason. And all of those opinions need to be there because the athlete's at the centre of that. And the athlete is technically on the end of those decisions, aren't they? So
I completely agree with that. And particularly when it comes to research in the women's injuries, I've really observed the benefit of that multidisciplinary collaboration with research. And I think it's something that's really lacking in a lot of sports and exercise medicine research in general, but particularly with regards to women's sports. And I think we're getting better at it, but I think it's crucial.
So I am a strength coach here in the US, and my athletes, if they get ACL tears, are always asking me, how am I going to feel after this? Is this going to limit my playing time? So if a 15-year-old footballer is considering ACL surgery, what are kind of long-term implications for their knee health and their future playing career?
So I will always allow quite a lot of time to have a chat with a patient who's done their ACL in their teenage years, because I think this is a really big injury for a young player. I always tell them the goal of surgery is not to get you back to being an elite athlete. It's to allow you to play your sport and to preserve your knee health in the future. We have evidence that the ACL injury itself is associated with a risk of post-traumatic arthritis 15 years down the line. I don't think we've got strong evidence of that in our younger patients, but we certainly see it in the adult population. So I do warn them about that. One of the reasons we do the surgery is to get them back to playing. But what you have to be mindful of at the age of 15 is that while you're out of play, your peers are going to rapidly accelerate past you while you're out. And I think it's really important to bear that in mind, that when managing their expectations, that I always say to my patients, you are welcome to prove me wrong. And I absolutely support you going for the highest level of sport you can get to, but you've got to be aware that people are going to keep going while you're static. And that's a bit different when you're an elite athlete and you're already at the top of your game. But when you're on that rise, kids have an exponential kind of improvement as they age and grow. You come out of that for a year and you may get left behind. And I think it's different in different sports. Something like football, where the competition is so fierce because so many people play it, I think you'd really struggle to get back. However, less popular or less common sports, you might find that gap is narrower.
Do you know what? I'm going to come in there slightly because that must have a massive psychological impact on some of those young athletes.
Yeah, absolutely. And I think managing adolescent ACL injuries, that's a real team sport. And I probably see my patients more frequently than my adult colleagues might see their ACL patients, because it's a real journey. And there's some really interesting time points that I observe. Their physios are often their biggest support network. And our physios have no psychological training, but deliver most of the psychological support to the patients. And you see these sort of time points, like the first 3 months where they can't do a lot is a bit miserable. And then when they start running, that gives them a bit of a confidence boost, but that can sometimes come with a bit of overconfidence and they think they can start doing a bit of their sport. I always see them at 6 months when they all want to start playing football. We just have a little reminder conversation about how they're not okay yet. And the other thing is, it's a really challenging and I think an interesting age, but adolescents, because they don't see long term, they see what's in front of them. Their prefrontal cortex isn't fully developed, so their decision making isn't optimal. However, they are becoming autonomous humans who want control over their body and their decision making, and I think we have to respect that as well. And I really believe that it's our job when managing adolescent athletes to give them the best opportunity to make their own decisions, but with support to guide them in the right direction.
I'll give you a little story, right? When I tore my ACL at 19, I always remember after having the surgery, and they delayed it a couple of times because I still had a very swollen knee. And this was over in the United States. And I remember the surgeon coming in and he said, "You're probably going to get arthritis." And I actually remember saying, "Yeah, that's okay." I do actually remember at 19 saying that. And now I'm kind of like, when I get that odd twinge, I'm like, yeah, I probably should have listened a little bit more there, Carolyn.
Doesn't mean anything to you at the age of 19.
No.
I have patients who are like, I don't care what happens in 3 years' time. I'm going to be at uni and I'm going to be doing something else. I want to play this sport now. This is what's important to me now. And I think it's a real balance though, because I think we shouldn't be too paternalistic with them, because they need to, because if you try and tell them what to do, they won't listen. And so I think it's really important to engage them as part of the conversation. And it's the thing I find most interesting about working with teenagers, I think, is trying to strike that balance as best as possible.
That's a great education piece, especially me being in physical therapy school of, hey, we got to slow down, but being positive and really just trying to meet them where they're at and go from there. I know we talked about this a little bit earlier, but we hear about growth plate concerns in young players. So is this going to impact our surgical techniques and rehab at all?
So rehab wise, not particularly, but certainly surgical technique, there's no real consensus at the moment on which technique you use for which age groups, but we do have a national complex pediatric knee MDT where we often come together and discuss which option we might go for. The evidence suggests that in your older teenagers who have got a little bit of growth left, that you won't get any clinical problems from doing a standard ACL reconstruction. But if you look really closely, you'll probably see some changes to growth. Obviously, the younger they are, the higher that risk is. And you can do things like calculate their bone age, looking at their hand x-rays. We monitor their alignment. And there are actually national guidelines on managing pediatric ACL injuries. And those include things like monitoring their alignment as they grow to check for any growth disturbance. And interestingly, going back to what we were talking about, non-surgical management, the guidelines say that if you're going for non-surgical management of a pediatric ACL injury, they need to be managed under very close supervision, kind of for the reasons that we talked about, where they're probably going to just go and crack on at some point and you need to be watching them closely if it happens.
I think we talk about when we're getting these young athletes back, right? We talk about that return to play timeline. And I think that message is out there. Look, it's 9 to 12 months before you want to return. However, with younger players, there has been that discussion as to, is that enough? Or should we be looking at a different timeline for younger players?
So I think I always say minimum of a year for
Mhm.
children. And what I say is that's a minimum of a year, but it's on a goals-based rehab program. So we don't work, none of the physios I work with have a time-based program. They all have a goals-based program. And what I say is we break that down a bit. That's not a year of doing nothing. That's a progression. And you'll start running at some point, and then you'll be doing some drills and you'll be doing some light training, but it's no full contact until a minimum of a year. There is some evidence that actually 2 years would be better for them. But I think the problem is we can't, for any patient who's had an ACL rupture, I think 2 years is where people are back to where they need to be. But no one can really face keeping people out for that long, which I think that's very reasonable. And that's why a lot of the physios I work with will implement the injury prevention strategy as part of their return to play. And they'll have that geared up and ready for some of that secondary prevention.
Yeah, and of course, you work with the charity Power Up to Play, don't you? You're an ambassador for them. And that's how you and I got chatting about how our lives were aligned and how we did a lot of things the same. Now, let's start to talk about that sort of return to play and prevention of secondary injury, because obviously that's going to be a big thing as well. Lotte, I think we've got some questions here, haven't you?
Yeah, so my project was preventing secondary ACL tears, but even just generally as a club, they're still not really adding in these prevention programs. So what kind of do you think is stopping them from implementing effective ACL prevention programs?
I think this is the $1 million question at the minute. And there's actually national strategy work going on that I'm involved in as well to try and tackle this in the UK. For me, I think it's multifactorial, like many things, because there's so many levels to injury prevention implementation. You've got the higher level, making it mandated from your governing bodies of the different sports, from schools, from health policy. And then at that kind of grassroots level, you need coaches to be educated and they need to buy into it as a concept. And then I think you've also, and I think this is maybe slightly underappreciated, you've got to get buy-in from an education from your players. A little bit like what we were talking about earlier with adolescents. If you've got your 8-year-olds, 9-year-olds, you can tell them what to do when you're coaching them. They'll mess around a bit, but they'll probably do as they're told. Your adolescents, they want to understand why they're doing something, if they're going to do something different or a bit new. So I think it's getting them bought in as well. And what I would really like to see is, and I think this would be particularly beneficial for the young women, is some role modeling of the value of injury prevention. Because I think often teenagers will look to their social media, they'll look around them to take things on like that and to buy into it. So as well as educating them, it's inspiring them to take it on.
Yeah, I like that perspective. And so in those prevention programs, I know that there's biomechanic changes, there's strength that we want to work on, there's neuromuscular kind of coordination. So what are the most overlooked aspects of an ACL injury prevention program for these youth athletes?
Just from chatting to people, when I often ask parents or patients, what's your warm-up look like? And interestingly, the first thing most parents say is they don't do enough stretching. They'll go, yeah, stretching is important. Totally agree. But what they'll often do is they'll do some running. They might do some change of direction stuff, but I think it's the plyometric element that probably gets missed the most. And that's going to give you both your neuromuscular and your strength work all in one. And for me, I think that's probably the most overlooked element of an injury prevention warm-up.
It's interesting because I was at a conference recently and there's some work going on in some UK schools. And basically they took the injury prevention protocols to the teachers. And of course, they showed them the Nordic hamstring exercise. And the teachers burst out laughing. They said, what kid do you think is going to go near another kid's bottom? That's what they said. And of course, we're like, but this is a great exercise. It prevents hamstring injury and it's great for ACLs. Like, why wouldn't you do this? And of course, the teachers went, there is no kid that is holding on to a kid's foot near somebody's bottom. It's not going to happen. So those are the types of barriers, the real life barriers that we probably need to start thinking about. Now, let's talk about biomechanics, because there's some clubs out there doing some biomechanics screening, not more elite clubs, of course. Do you feel that's actually preventative with regards to injury? Because It's very interesting that some of this stuff is now starting to be questioned. Is it the wideness of our hips, or is it the fact that we are actually just not given the same access to facilities and strengthening that everybody else is? Because I'm at that point of the more I read, the less I know.
Yes. I know what you mean. I think the biomechanics screening is really interesting, and I'm interested to see what the evidence shows. But I think, again, a little bit like the hormones, there's some bigger hitters that we can attack before we start looking at nuances of biomechanical screening. As you say, equal access to resources, inputting strength work at a younger age in young girls. Society does not set young girls up to want to be strong. And that comes from all directions. And that's just a massive, if you shift that sort of cultural change, I think that would have huge impacts. And the only really strong evidence we have with ACLs, both in youth athletes and particularly young women, is that these neuromuscular warm-ups benefit them and reduce their injuries by 70% in teenage girls who do the Santa Monica PET program. So yes, there's lots of cool stuff happening. And again, at your elite levels, probably you don't need to be doing big neuromuscular warm-ups. They probably have got some strength and conditioning work. But before they got there, they've got this whole journey of their grassroots experience and their academy experience where they've not had all that work done. And if we can hit the grassroots, I think that will have a massive impact on our elite level as well.
So is there evidence that neuromuscular training from a young age is going to reduce ACL risk for older players?
So I've not seen any evidence specifically relating to that. I think it's more a common sense. And if you look at the fact that young boys get strength and conditioning work earlier, and therefore when they are moving into their academy world, they're getting more strength and conditioning. For me, it's a logical progression that one of the reasons, and you see this in women's rugby, I think, where women's rugby isn't professionalized in the same way as women's football. And a lot of the women who are playing at a sort of professional level are not of the condition or shape that their male counterparts are. Whereas when you look at your elite female footballers, they are physically developed and invested in a similar way to their male counterparts. So you know what it can be like at your top levels, but there's this huge gap in between of female athletes who aren't getting that work put into them. So I'm not suggesting that it is the answer to all female ACL injuries, but it just makes logical sense that if you invest in strength and conditioning at a young age, and then we're starting to see this more as women in society generally in the older end of the age spectrum, when you're hitting perimenopause, that actually if you strengthen up our perimenopausal and menopausal women, that's going to have a huge impact on them and reduce their risk of injury in later life. So I think, although I don't see any specific evidence saying that neuromuscular warm-ups in grassroots will impact on their ability to be an elite athlete later, I think it just makes logical sense.
Yeah. And a personal anecdote is I've been strength training since I was a kid. So even possibly just that consistency of, hey, I'm doing this and I'm going to keep doing it. And just that consistency of a strength program can just lead to better outcomes in having that for most athletes.
And likewise, if you reduce your injury burden in your adolescent group, you get an ACL injury as a teenager, your chance of being an elite athlete is much lower. You prevent that injury in the adolescent group, that player can then potentially go on and progress.
Yeah. I got asked this question recently when I was being interviewed, and it actually made me relatively slightly uncomfortable, because I basically got asked if there was one change that you could make to reduce ACL injuries in young female players, what would it be?
One change.
I know, for a multifactorial risk.
I think if injury prevention warm-ups became mandated in grassroots sports, I think that would have the biggest impact on our ACL burden in youth athletes, and particularly in young women.
Yeah. And it's funny because at that conference that you and I were at a few kind of weeks ago, I basically I stood up and said, at what point does this have to become part of health and safety policy to avoid a legal challenge if you are an employed member of staff running a session? I don't understand. I'm actually surprised it's not happened already, to be honest, but I'll be interested to see if there are any changes there. Now, let's talk about our key kind of takeaways. Lotte.
So if a young player or coach or parent is listening to this podcast and they're worried about ACL risk, or they've had a player who's had a tear and they're looking at recovery, what is your biggest piece of advice that you would give to them?
So I think people who are worried about an injury or preventing further injury, I'd definitely signpost people to the Power Up to Play website. There's also an Instagram and a Twitter handle, depending on your social media platform of choice. We're not quite on TikTok yet because we're not quite that cool, but certainly from that perspective. In terms of recovery, I think talking to other players, there will be people around to talk to, and sharing experience is going to be really key. And I'm often asked that by parents, like, how do I get my kid through this? And we don't have huge resources from that perspective, but I would definitely say peer support and physio gym clubs are often a good place for that. But certainly for the prevention perspective, checking out the website, and there's a contact button on the website where parents and coaches can get in touch with the charity, and they can be directed to their local ambassador who can do sessions with the coaches to educate them about the warm up, give them resources to deliver it, come and train up all their other coaches. And we've got over 80 ambassadors across the country now, so that shouldn't be too difficult to implement.
That has been absolutely fantastic. Lotte, I have to say, you did absolutely amazing today. Well done. Morgan, it's been lovely to have you here, as it always is to have a chat with you. To any of our listeners who are listening and they want to learn more about these injury prevention programmes, they are all linked on our website as well, womensfootballhub.com. Go to the coaches area and they're all linked there. Morgan, I'll talk to you about getting a Power Up to Play link on there as well, so people can get in contact with you. And if you are working with young players, please remember that prevention of these injuries is absolutely crucial. And please always follow the evidence. We will see you soon.
Thank you for listening to Women's Football Hub. The information within this podcast is for informational purposes only. No material on this podcast is intended to be a substitute for medical advice, diagnosis, or treatment. Please contact your doctor or another healthcare professional if you have any questions about anything raised in this podcast.